Hello and welcome to Everyday Medicine. I'm Dr. Luke, and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for medical practices. In this podcast, we're talking with a neuropsychologist on the subject of memory. But before starting, for Australian audiences, listening does give you eligibility for your CPD, so log in and make this an activity. You may also consider journaling, reflection and adding to the review and performance section in your CPD. Well, memory is the cognitive process of acquiring, storing and retrieving information. It's the mind's ability to encode, store and recall experiences and knowledge, allowing for learning, adaptation and the formation of personal identity. There are different types of memory, including short-term memory, where information is held briefly, and long-term memory, where information is held for extended periods. There is sensory memory, where information relating to senses such as sight, sound and smell are retained. Explicit memory, recalling memories or facts and events. And implicit memory that influences our behaviour without conscious awareness, for example, like riding a bike or driving your car. Memory storage involves multiple brain regions, but the hippocampus is crucial for forming new memories, especially long-term memories, and acts as a gateway for encoding and consolidating memories. The cerebral cortex and prefrontal cortex are also very important and participate in memory storage and retrieval. Without memory, our enjoyment of life's wonderful pleasures and diversity is severely compromised, and unfortunately, memory loss is also a key feature of dementia and often cited as an early clinical marker of cognitive decline in a patient who is starting to have difficulty coping with the complexity of life, their medication schedule, shopping lists, and daily tasks. Well, I was curious to understand how we may improve our own memories whilst also providing advice in terms of exercises that may benefit our patients coping with early cognitive decline. Simonides of Chios in 500 BC is credited with developing the method of loci, or room method, of memory recall, where an earthquake collapsed the roof at a banquet he had just attended, killing all inside. Relying on his visual memory, he was able to accurately identify the corpses by precisely recalling their seating arrangements as he had noticed them while he was reciting poetry for the guests. This method, now popularised by many teaching memory techniques, highlights the value of linking things we need to remember together to enhance their recall. It's also interesting that memory for music and songs is often retained until late in cognitive decline. I was keen to explore the ideas behind the complex subject of memory in more detail and was honoured to invite Dr. Natalie Grima, who is a clinical neuropsychologist, to the podcast to expand our knowledge and understanding. Dr. Grima is a Melbourne-based neuropsychologist and founder of Neuropsychological Counselling Australia. She is a senior clinical neuropsychologist at Monash Health, has published widely, completing a doctorate at Monash University and undertaking advanced clinical training at Harvard Medical School. Natalie has a special interest in the diagnosis of dementia, psychiatric conditions and cognitive rehabilitation following acquired brain injuries. She has an expert knowledge on the subject of memory, so please welcome her to the podcast. So, Dr. Natalie Grima, welcome to Everyday Medicine, and thank you very much for taking time out of your busy schedule as a neuropsychologist to talk about memory with us today. Natalie, I really appreciate your contribution.
Thanks, Luke. Thanks for having me on.
Yes, so we have to blame Helene, your good friend, a neurologist, for dobbing you in, Natalie, and it's such an honour to have you here. And I thought it would be very helpful for us to cover the topic of memory. And before we perhaps launch into that, you're a neuropsychologist. Can you tell us a little bit about your journey into neuropsychology and the sort of work that you do?
Yeah, thanks. Well, my interest in neuropsychology really began in high school, really, when I took psychology in VCE, and I really was interested in the workings of the brain, but I didn't know neuropsychology existed as a field. Most people think of clinical psychologists when they think of psychology, not neuropsychologists.
Yeah.
And it wasn't until I stumbled across a program at university where I majored in neurophysiology and psychology, and I did a double major in those. And that's where I really took a deep dive in terms of understanding how the brain worked. And at that point, I still didn't know neuropsychology existed. it wasn't until my honours that I discovered the field of neuropsychology, and I absolutely fell in love with it, and I've never looked back since then.
I think, Natalie, you're right, that most of us tend to think about psychology in terms of clinical psychology of patients who have got emotional needs. You know, they've been through some trauma that they need to talk through. Maybe as doctors, we're not the best people to do that, so we tend to defer to clinical psychologists. But I would have to say that I have probably been ignorant of your place in medicine and in the clinical field. What sort of people are sent to you, and who should we be sending to you as clinicians?
Yeah, so that's a really good question, and just to underscore the fact that most physicians don't even know what I do, and let alone what my profession is. Neuropsychology is really sort of that interface between neurology, psychiatry, neuropsychiatry, and even psychiatry as well. And so I work very closely with neurologists and also psychiatrists as well in terms of understanding brain behaviour relationships. So neuropsychology, really bore out of a lot of clinicians, Luria being one. There were other clinicians in Boston as well, where they really tried to unpack the way the brain worked and how that was manifesting clinically. There was a lot of single case studies that sort of elucidated the role of the way in which the brain worked, and which is, Oliver Sacks being one of them. He was a very talented neurologist who was able to really sort of explain what was actually happening clinically and relating that to the neurophysiology underpinning that. And that's essentially what we do as neuropsychologists. We're really trying to sort of unpack what's going on for patients. So we see a broad range of neurological and psychiatric conditions coming to clinic. So, I work with patients with traumatic brain injuries, concussion. I play an instrumental role in terms of diagnosing the different dementia syndromes as well. And also other types of neurological conditions like autoimmune conditions like MS, epilepsy as well. Neuropsychologists play a big role in terms of understanding how memory works in that condition. And also the impact of psychiatric conditions as well in terms of, the way in which people think and how that impacts them. Neuropsychologists are famously known for doing capacity assessments, so that's one part of our role. And we certainly work very closely in terms of helping physicians understand what patients can understand and how to approach them.
I see. That's very helpful. Yeah. So, I think probably at the close of this conversation, we're going to have a lot of primary physicians who'll be thinking, gosh, we should be using neuropsychologists a little bit more. In general, when you're seeing these patients, you're explaining to the patient, giving them a deeper understanding of where their problems sit in terms of their behaviour and their brain function. Are you able to give them a whole range of exercises that they can maybe start and undertake that may improve the outcome for them in terms of their clinical problems?
Yeah, absolutely. And again, I'm trained, with the scientist practitioner model, meaning that, when I'm assessing someone's cognition, I'm looking at things like their overall intellect, their attention, their planning skills, their executive functioning abilities, how well they're processing visual information.
Yeah.
So I'm looking at all of their cognitive profile and trying to look for islands of strengths and weaknesses, and really trying to then tailor recommendations to support them in the things that they're wanting to achieve in life.
Well, thank you. With that background, we want to talk a little bit about memory. And it's said that up to 40% of our population over the age of 65 start to have some memory retention problems. And I don't know how true this is, but I felt my memory just went off a little bit when I got COVID. I've had COVID a few times. I just felt that all of a sudden there were some things that I just had to think about almost from a strange angle to try and prompt my memory. I had to sort of try and pin my memory to other events so I could remember a name, remember what it was that I was trying to talk about. I'm not sure how true that is of other people's experiences, but I just wanted to explore your thoughts about how memory works. Can you just bring us up to speed on that? What's the current understanding of this weird thing we have in our brain called memory?
Yeah, and this is one of the top referrals to a neuropsychologist, because we if any of your audience members have seen a neuropsychology report, we're famous for writing long reports, though I'm not one of them. But memory isn't a single thing. It's a set of processes that allow us to sort of take in, store, and retrieve information. And at the broadest level, we sort of talk about two different types of memory. We talk about explicit memory, which is what we can consciously recall, and more implicit or procedural memory. And I'll focus more on explicit memory because that includes your episodic memory or your autobiographical memory, your memory of your personal experiences. And then the other component to explicit memory is semantic memory, which is our knowledge about facts, about the world. And so there are various theories about how memory works, but most agree that there are three core stages of memory. So there's encoding, storage, and retrieval. And when I'm explaining this to patients, I often use the filing cabinet analogy. So encoding is like writing on a document and labelling it clearly. And storage is actually filing it away in the filing cabinet, whereas retrieval is going back and pulling out that document when you need it. So if something goes wrong at any of those three stages, say the label's too vague or you haven't stored it correctly, you may not be able to access the memory later. And there's sort of different parts of the brain that are responsible for memory. There's been a lot of single case studies in terms of helping us with that, fMRI studies as well. But we know that, for example, the prefrontal cortex is heavily involved in terms of encoding new memories. The mesial temporal lobe and the hippocampus in particular is especially important when it comes to consolidating memories and also retrieval as well. We know that when you are storing information, the memories are stored also in various parts of the neocortex as well. So it's a whole sort of system that there's multiple systems involved with that.
I see. It's interesting. And repetition, if I'm trying to remember something, I find if I tell people about it, it might be a medical fact. I sort of am repeating, I've read it, then I repeat it. I might tell it during an endoscopy session to some of my colleagues, but it sort of reinforces it. And that repetition allows me to remember it way better than I would otherwise. And I've read about memory books and these memory championships and the various methods that are used to try and pin a memory to something. It may be something you're familiar with. You might take your room and you'll pin your memory to, there'll be something you'll pin to the door, something you'll pin to a book on a bookshelf, something you'll pin to something that's out that you can recall on your desk. It seems like there are lots of different ways in which people sort of try and hook their memory together.
Yeah, absolutely.
Yeah.
I mean, the other thing to say as well, the other sort of concept that we explain to patients as well is that, you know, there's different types of memory. So particularly in someone who's right-handed dominant, particularly their left hemisphere is more involved in terms of acquiring verbal information, and your right hemisphere is involved more in the processing of visual information. And really what we're trying to do with patients is help them realise that if they are encountering difficulties with new learning and retrieval, they actually need to really understand the point at which it's breaking down for them, and that's what neuropsychologists can do. But it's also about then helping them educate them about ways to improve that. So one of the things that you sort of touched on that routinely comes up in clinic is this idea of sort of this forgetting over time.
Yes.
And I often sort of lean on the work of Professor Daniel Shatner, who's at Harvard University, who's a very well-known memory researcher. And he sort of talks about the 7 sins of memory. And one of the sins of memory is the sin of transience, which is this phenomena wherein you sort of forget information over time. We know from cognitive psychology, for example, we often refer to the Ebbinghaus effect, which is that we gradually forget information quickly if we don't review it and repeat it. So, you know, your recollection of what you did yesterday is probably very detailed and rich versus your memory of what happened last Monday, particularly if it wasn't, a salient day, there was nothing emotionally, notable about that day. And so the reason I make that point is because when we're telling patients about how they can utilise ways to bolster their memory, we're really emphasising the point that when it comes to repeating it, It's about repeating that information in a way that's meaningful for them, where they're really relating that information to other things they know, but also repeating it at different intervals after, their initial exposure to that material, and also playing around with that information as well to make it novel.
Yes. So just some other examples you can give me of that. So if someone comes to you, they're referred to you, and perhaps they're heading into their late 60s or early 70s, and they're a little bit concerned about their loss of being able to recall, maybe names or whatever. What sort of practical things, and GPs will face this, I'm sure, in their clinical practice, what sort of practical things could you point them toward to help them?
Yeah, so first of all, it's trying to understand at the level at which the memory is breaking down. And, the other thing to say is that your ability to hold on to new information is something that does change with age. For most listeners of this podcast, the good thing is that higher levels of education seems to protect the brain from losing information over time. But still, you still are dealing with very, high level individuals, who are highly educated, who are still noticing that there's changes with their memory.
Yes.
I mean, when it comes to memory, there are practical strategies that can be employed. So you sort of alluded to some of the strategies that are employed by memory champions, like the method of loci, and we're trying to visualize, trying to have a verbal, piece of information and linking that with something visual. So it's really utilising both hemispheres of the brain. That I find clinically in patients coming to me is just too overwhelming. Often they're just so overwhelmed by that it's not very helpful. And so it's really sort of gauging at what level patients are open to sort of implementing strategies like that, because it is quite effortful and onerous on them. But, the other strategies which are really helpful is really trying to use external memory strategies. So writing information down and being really organised about where they're keeping information. So if they need to recall prospective events, and they're having troubles with that, or having troubles with, remembering things that they need to buy at the shops or things that they need to do for the day, it's about trying to create some organisation and structure. So one thing is having a diary or a calendar where they are religiously inputting information into that and checking it throughout the day. The other thing to say that I find helpful is getting patients to think about the way in which and where they're storing their belongings at home. So, misplacing their keys and their phone and all those sorts of things. And I sort of talk about a memory table where we get patients to religiously put things in a certain place. And by doing that, it becomes more procedural. If you're not explicitly thinking about, placing your keys and phone in a particular area, it becomes procedural over time. It becomes more of a motor memory. And that is something that can help patients as well.
Yeah, that's very helpful. Do you feel that, like, with the onset of very early dementia, that these sorts of little strategies that you've just introduced there, they help? I mean, they'll help someone perhaps in the moment, but do you think they help to delay the progression of the memory loss?
No, do you mean in terms of these memory strategies?
Yes.
Yeah. I think it's just about these memory strategies just help people cope with the changes that are going on with their memory.
Yes.
I think that when you're talking about helping people mitigate risk of further cognitive decline and even pushing back against dementia, that's when we need to take a bit more of a holistic view about their health. And so, I'm particularly interested in this area myself clinically, and I've done a bit of research in this, but, there are certain things that people need to look at holistically about their whole health. So for example, the core things that we need to be thinking about is nutrition. And so there's certainly studies out there looking at particular diets like the MIND diet or the DASH diet, which really emphasise, the Mediterranean diet, making sure you're optimising your omega-3 fatty acids, increasing and optimising, antioxidants in your diet, and fibre, and minimising saturated fat, and animal fat. Sleep is another one as well. It's not uncommon for patients to come in and, they've got potentially sleep apnea, They've got increased daytime somnolence as well. They're just not sleeping great. And so I've done a bit of research in this area showing that, even short sleepers and long sleepers, that's potentially a risk factor for cognitive decline in the future. The good thing with sleep is that we've got so many treatments available to help address that. So, if patients are coming to me with insomnia, we know that cognitive behavioural therapy for insomnia is very useful for patients in terms of improving sleep duration and quality beyond sleep hygiene. And, we've even got treatments for obstructive sleep apnea as well. So I really try to emphasise those things. Physical exercise is another one as well. And there's been some really, well-run sort of clinical trials looking at the use of aerobic exercise and also strength-based exercises as well in women and patients who are showing mild cognitive impairment.
Yes.
But again, all of these things, it's about how do we package this for patients in a way that's not overwhelming and that's manageable. And I think that that's where medicine today is probably struggling a little bit in terms of managing this. Is going to become an issue for us. But we know that, up to 45% of dementias are potentially reversible by implementing all of these strategies.
Yeah.
So that's certainly an area of interest to me.
Yes. Oh, that's very interesting. I think probably also, alcohol reduction is another factor that often patients don't reveal the amount that they're consuming.
Yeah.
We often get clues clinically from looking at their liver function tests and, indirectly talking to family members. But that's another big factor, I think, isn't it? I did see on the ABC many years ago a discussion about memory, and I'm not sure what your take is on this, but one of the points that was raised, which I'm not sure how evidence-based this was, but the talk was, well, you can learn an instrument, try learn a language, dance, juggle. I think using the brain in different ways. Do you have much of a feeling about that? For some of our more senior citizens entering, the phase where they're worried about memory, is that helpful? People used to talk about crosswords and Sudoku. I'm not sure how helpful all those things are, but do you have any comments about those sorts of things?
Yeah, I do. And that's something else that I talk about with patients as well. And I sort of frame it as cognitive social engagement and stimulation. So, a lot of the early research, one of my labs that I was in my early research days sort of focused on looking at cognitive training and seeing whether or not that afforded patients, improvements in day-to-day, everyday memory. We know that if people are engaging in sort of cognitive tasks, particularly brain training programs to help with improving their memory, it doesn't necessarily translate into everyday memory for them. They just get better at that particular task. But the good thing is that by getting patients to maybe think about taking on a new hobby, whether that's dancing, learning another language, certainly bilingualism is certainly something that can help reduce the risk of dementia, and it builds that cognitive reserve and that slows that cognitive decline. That's really helpful. Engaging in meaningful conversations. One of the things that I often see and I'm really concerned about is that I see so many patients 60 plus coming through who are isolated and alone. And so they're not engaging with the community around them. They're not having meaningful conversations. Having a meaningful conversation with someone is cognitively demanding and taxing. And that is actually really good exercise for your brain.
Yes.
And so, I'm constantly trying to sort of help change people's perceptions about what it is to actually get their brain going beyond doing Sudoku, every day.
Social engagement, very, very important. Yeah. Have you seen patients, Natalie, that have been referred to because they've had a memory losses from COVID? I'll just come back to that. Is that something that you're seeing, or is it that you're not entirely convincing on that?
Yeah, look, I have seen, a few cases. Are you talking more about sort of long COVID, cognitive impairment?
Yes, that sort of thing. I did see a report, but I'm not sure. Like sometimes the reports are in the literature and they're not really verified that there might be a slight change in the brain volume.
Yeah,
post-COVID,
I think
but I don't know how true this
is. Yeah, there's multiple mechanisms that are underlying that, from my understanding, and that'd be sort of inflammation, potential cerebrovascular changes, and what I tend to see when I'm looking at their profiles is aberrations in their working memory and their attentional system, particularly. Again, your attention and working memory is very much fundamental in terms of being able to encode new information. And patients will often report this experience of brain fog as well, where there's no clarity of thought.
Yes.
And that can be very disabling for patients. It's very similar to patients who are coming to me with brain fog following a concussion as well.
Yeah.
And so the way I've found in terms of working with those clients is really taking more of a biopsychosocial approach. I'm acknowledging, the changes with their attention and working memory, but I'm also looking at other factors as well. So I'm looking at their sleep, the stress that's going on, their mental health as well. That's really important. Often that's not acknowledged. And also just looking at their general sort of, day-to-day engagement in physical activity, stress management as well. All of those factors are important.
That's very helpful. I did read last year in one of the journals about Shingrix vaccine and a large study in Wales suggesting that that vaccination might help to stave off dementia, improve memory and so forth, which is very interesting. And the exact mechanism wasn't clear, but it's very interesting in terms of, the effect of viruses on our memory. I think here we're talking about practical things, and you've given some great ideas that would help us in clinical practice to assist our patients. Do you think there's any value of medications that you've seen or supplements? Is there any value that you're aware of? Or is it, there's anecdotes perhaps, but just what's your take on that subject?
Yeah, I've spent a lot of time in this area. One of the first labs I worked in was the Centre of Human Psychopharmacology, where we were sort of looking at different nutraceuticals like Bacopa, Monniera, for example, omega-3 fatty supplementation as well. As a clinician now, when I'm seeing patients, one of the things I'm particularly concerned about is older patients who are coming through who have a very restricted diet. Those are the patients I'm particularly concerned about, particularly if they're coming to me and there's the presence of a metabolic syndrome as well. There's obesity. So, I'm often sort of educating patients about tackling what I call low-hanging fruit, which is looking at their vascular health, their cardiovascular health as well. There's many medications there that can be used to manage hypertension, also looking at insulin as well, and potentially for the management of diabetes, looking at their blood sugar levels. So getting patients to look at those things, I'm a real advocate for that, because we know that your cardiovascular health is certainly a risk factor for cerebrovascular disease, which also then increases your risk for Alzheimer's disease as well. And we know that for Alzheimer's disease, there's a co-occurrence of cerebrovascular disease as well. So those are the things that I get my patients to think about. In terms of, if they've considered all of those things and they're optimising their diet, then, there are some patients who will go down the path of potentially using Bacopa, vitamin B supplements, all those sorts of things. But I think there's a lot that patients can do before they even get to that point. And the other thing is, when I'm really concerned about a patient, particularly their diet, I'm often referring to a gastroenterologist and a dietitian as well to say, to help them think about other foods that they can be incorporating to actually support their cardiovascular health and also their memory as well.
Yes, that's a good point. You're quite right. Often people do take supplements, but they don't focus on exercise, good sleep, and all the other things that might look like medicine 101 to you, and they sort of forget that. And they perhaps think, I'll just take that because it's the easy path to an outcome, which is anecdotal rather than proven.
But I guess, there are some cases where it's really important, particularly if someone's, consuming a lot of alcohol. I'm really emphasising for them to be, taking vitamin B supplements, while they're working with a psychiatrist to try and help manage that. There are certain conditions, even particularly women as well, potentially with a history of eating disorders as well. They're ones, I'm particularly concerned about them. Yes. And again, I would be really emphasising the need potentially for supplementation. But again, working with their physician to see if there are other ways in which they can work on optimising their diet.
Natalie, Natalie, you've taken us through a very, very helpful sort of practice summary on memory, and I'm very excited to have met you because I don't think I didn't appreciate that you existed, your services existed, which is rather embarrassing for me. But maybe other people now will know about you as I do. If we wanted to refer a patient to, first of all, do you need a referral from a doctor? Can patients just see you without a referral? Or how does that whole process work, Natalie, if we want to send our patients who are in need of your services?
Yeah, look, no, patients can self-refer. I mean, within the public health system, all of the public health systems in Victoria and most of the other states have neuropsychologists there. And so I would encourage you to inquire about the different referral pathways. Outside of the public health system, there are many neuropsychologists that work privately. For patients under 65, if they've met NDIS access, they can potentially use the NDIS funds to get access to a neuropsychologist. So that's always there as well.
Yes.
A lot of rehabilitation centres that are sort of affiliated with hospitals also have a neuropsychologist there. But, we are a small workforce. So I think in Victoria we've got less than 500 clinicians that practice as neuropsychologists. So, we're often in
the big ratio. How many sessions do people, I guess it varies, of course, but generally how many sessions do patients need who've come to you? Maybe they've had a CVA and they're trying, or some TIAs, and they're just worried about their memory and they're trying to improve their cognitive function and so forth. How many sessions would you on average tend to take?
So it really depends the type of assessment. So if it's more of a diagnostic assessment, it might just be a once-off assessment and then feedback thereafter. And, within a rehabilitation framework, that could involve one assessment for a couple of hours and then ongoing subsequent sessions with a neuropsychologist to sort of work on particular strategies.
Yes.
So it does vary. But often our assessments are hours. They're a couple of hours long. We spend a lot of time sort of understanding patients in terms of their neurodevelopmental history, their psychiatric history, neurological history, medical history, and weaving that in with their cognitive complaint, understanding that, and then comprehensive cognitive assessment as well from there, which culminates in a report. So I guess the other thing to say as well that can be helpful for GPs, particularly, who are coming across patients with memory problems, there are, cognitive screening tools available for them. So the MMSE being one, I would say that's probably, if patients are doing well on that, it just tells us that they're oriented and alert. But the other cognitive screening measure, which is really helpful, is the MoCA. And that can be really helpful in trying to understand if there is a more sinister memory complaint. If there is, that may warrant a referral to a neuropsychologist and also even a cognitive neurologist as well.
Can you repeat that last one, MoCA?
Cognitive neurologist.
Yeah. Sorry. That test, MoCA.
The Montreal Cognitive Assessment.
Montreal.
So it's called the MoCA, MoCA, which is again widely available.
Right.
That can be really helpful. Often, a lot of hospitals use that. So if a patient is referred with a really low MoCA score, or there's signs that they're having memory problems, that means something to the specialist and to a neuropsychologist. That helps us target prioritise the referral and also enables us to really target their memory system in a bit more detail.
Natalie, I'm so grateful that you've taken the time to come on and have this conversation with me. And obviously, we're very proud to have someone of your skill set in Melbourne. And I'm looking forward to introducing my patients to you, when they're appropriate. And I wish you all the very best in your clinical practice. And I'll draw people's attention to your clinical practice in the show notes when this podcast is produced. So I'd like to thank you so much for taking the time to meet me and converse with me today, Natalie. Thank you.
Thanks, Luke. It's been a pleasure.
Thank you very much. I'd like to thank you all for joining me on this podcast series with Dr. Natalie Grima, where we've discussed memory. Natalie provides a very comprehensive service for patients who are experiencing cognitive decline, and I'd like to draw your attention to perhaps referring to her in the future if such patients are in your rooms and you feel may benefit from this assistance. During the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and they reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@gihealth.com.au.